Afternoon, so we got a couple more lectures to get through. I'm going to get through shock. I'm going to get through some blood gases. I'm going to get through some basic ventilator stuff. I'm going to leave most of the ventilator stuff for Sean to explain because I think slides don't do ventilators justice. And so what we'll do is I think hands-on is going to be so much more important. And then what we'll do after that is we will spend a little bit of time just about a little bit of time on ARDS management. What are some of the strategies that we can use in ARDS, and what are we talking about when we talk about lopping or recruiting lung? So that's going to be the plan after lunch. I'm thinking we'll probably get to skill stations by about 2:30ish, and then you'll have a couple of hours to run through all the skill stations here. Maybe we'll run through them as a group, and then people want to practice one particular skill or do an IO, for example, that you've never done before, or just practice with an LMA or something like that. We have more time to practice. Is that all right with everybody? Okay. Okay. Yes. Okay.
So when you're demonstrating or doing a
demonstration,
just make sure that it can be over here too. It can be over anywhere.
So
just to let you
the
know.
line of sight. Okay, perfect. Okay. So one of the ways that we measure cardiac function at the bedside is you have to have an A-line for it. You have to have an arterial catheter. This is our Flotrac. So I don't know if anybody's used a Flotrac before, but it's kind of like a simpler way of measuring cardiac output and cardiac indices when someone is potentially in shock, rather than putting in a central venous catheter and measuring a pulmonary capillary filling pressure, i.e. through a pulmonary artery catheter. So the thing with the Flotrac is it gives you these really nice numbers and these bedside screens, but the truth is that it gives you a lot of information as long as the patient is in sinus rhythm. Because what it is actually doing, Flotrac is looking at the variation in pulse pressure as an indicator of the patient's cardiac output. Remember I told you that if you inflate the lungs too much, what happens is there's no cardiac output because there's no venous return. So the more sensitive the heart is to preload, i.e. with respiration in and out, the higher your stroke volume variation will be. So people who are breathing and they get a breath and their pulse waveform on the arterial catheter begins to drop, that means that their perfusion pressure, which is sort of related to their cardiac output, is very sensitive to inspiration and expiration. So the Flotrac is something we can use. All you really need is an A-line, okay, and this monitor. So what does it give you? It gives you the stroke volume variation, so the higher it is, the drier the patient is, okay? The more sensitive they are to inspiration and expiration, intrathoracic pressure, bless you. It also gives you the cardiac index, which is calculated from this, okay? So it gives you an idea now, not only the stroke volume variation, but the cardiac index. So if somebody has a very poor failing heart, you can use this as a surrogate. And then you can also get some other numbers, and then once again, you can put this whole thing together. What's really nice, it actually has a bedside, Starling curve. So the Starling curve, it has this little dot to tell you where you are on the Starling curve. So it actually makes it very simple for you to interpret the numbers and tell you how close you are to being full or how far away you are and how much volume you have to give. So again, it is a continuous bedside monitor, and you can use this at the bedside to resuscitate someone. And once again, the data is being fed to you very, very in real time, and you can use these numbers, the cardiac index, the stroke volume variation. So these are just different screens that you can scroll through on your Flotrac monitor. Some folks are using it in the OR, some folks are not, but it is commonly used in the ICU, and it can be used in any of the ICU settings as long as the patient has an arterial catheter. So once again, with expiration, if you have an inspiratory change, these changes are related to your cardiac output in hypovolemia states. So the larger the stroke volume number, the greater the hypovolemia. The more sensitive you are to changes in your intrathoracic pressure. Once again, remember we talked about codes where somebody's overbagging and they're dynamically hyperinflating the chest and the cardiac output drops. So that's a situation, that's the extreme situation where somebody is, very hyperinflated, they have no cardiac output or because they have no venous return. On the other hand, this is something a little bit more simpler, but it gives you an idea of how much more fluid you have to give someone in order to bring them up to their optimal filling pressures. So we talked a little bit about hypotension with lactate with fluids. Now we're going to talk a little bit about hypotension not responding to initial fluid boluses. How do we treat that? We use vasopressors. The nice thing about vasopressors is sometimes you can actually institute vasopressors. If you do it for the right reason, it's okay to institute it early. So somebody can be really hypotensive and you know in your heart the patient needs fluid. But you know in your heart that even barreling in fluid is going to take a little bit of time. So you get a little bit of vasopressors started, especially something like phenylephrine that doesn't increase the heart rate because it's a pure alpha agonist. And then what you do is you buy yourself enough time to fill the tank. The fallacy is that if you go ahead and you use vasopressors in the setting of shock, when patients are already almost maximally vasoconstricted, and you forget to give the fluids or you don't give enough fluids, that's where you run into really big problems. So buying time with vasopressors is kind of like getting a loan from the bank, okay? It just buys you a little bit of time until you get to the point you've now filled up the tank. So once again, mean arterial blood pressure is 65 or higher. Some people say it should be 70 to 75, certainly. People who have chronic hypertension have what they call their autoregulation curve, has been shifted a little bit to the right. And in those patients, their body is used to seeing higher perfusion pressures. So somebody, for example, who has chronic hypertension and they have a systolic blood pressure of 110, they could be relatively hypovolemic and symptomatically hypotensive. And rather than somebody who has a chronic blood pressure of 120, they drop to the same blood pressure, it means nothing at all, right? So again, it depends on what your body is used to seeing. You take a diabetic who has elevated glucose levels at baseline of 140, 180, for example, those patients may very well be symptomatic when their blood pressure hits 110. Okay, whereas a non-diabetic will be fine with that. So again, autoregulation depends on what your usual homeostatic point is and where your range of normal is for your body. And that's where you regulate it to. So this is very, very important. So hypertensives may need a higher perfusion pressure. Norepinephrine is a first-line vasopressor, but you've got to be careful because norepinephrine stimulates alpha and beta receptors. And when it stimulates beta receptors, it can exacerbate tachycardia. And if you have an exacerbation of tachycardia, your heart's beating faster. If your heart's beating faster, there's not enough time for your heart to fill because your heart fills during diastole. So you have impaired diastolic filling time, and when your heart is not filling, it can't pump. The heart's contracting on an empty chamber. So you get to a point in tachycardia where cardiac output begins to drop. Cardiac output, remember we talked about cardiac output being stroke volume times heart rate, right? Heart rate's really important, but heart rate can be excessive as well. So you've got to be careful if you use something like norepinephrine or epinephrine as a vasopressor because it'll increase the heart rate in tachycardia because the tachycardia is A, compensatory to hypovolemia, and B, because now you're stimulating beta receptors on top of that. So now you've got an overreactive tachycardia, which is detrimental in that particular physiologic state. Does that make sense to everybody? I can't repeat it. So if I can't repeat it, I can go through it again, though. Anybody not get it? Okay, fair enough. So second-line vasopressors are appropriate for those who have persistent hypotension. These can include epinephrine, phenylephrine, or vasopressin, and I'll talk a little bit about these drugs. So here are like dopamine, for example. We don't use a lot of dopamine anymore. Dopamine has been shown to be very detrimental in shock. Okay, it's a very bad drug to use. People talk about, oh, dopamine spares the kidneys, renal dose dopamine, so good. It's actually not good. So if anybody here is still using dopamine, forget it. Get rid of dopamine. Dopamine has very, very limited utility, and it's usually not used in critical care anymore. So in any case, phenylephrine is a pure alpha agonist, so it constricts blood vessels, okay, by binding to alpha receptors. Because it does not affect beta receptors, it doesn't cause tachycardia. So once again, sometimes you find people who are tacking along at 145, you start them on the quote-unquote first-line vasopressor of norepinephrine, and you have this 85-year-old little lady, now bang, she's in atrial fibrillation because you've overstimulated her, okay? She can't get any faster. So the thing is, sometimes it's a better choice to use something like phenylephrine in those situations. Even though it's not technically the first-line vasopressor, it is a matter of good judgment, okay? So again, norepinephrine Again, here is very important. Okay, this is your first-line vasopressor. It does stimulate beta agonist, and it also stimulates alpha receptors. It's more active at alpha receptors, so it does cause more of a blood pressure bang for your buck than it does for norepinephrine for beta receptors. But again, this is your first-line vasopressor. Epinephrine is really what it is an inotropic agent. It increases cardiac contractility. It's a really strong beta-1 agonist. And so it'll increase the heart rate, but it'll also increase the contractility of that heart. So in people with low cardiac output states, like people who are in cardiogenic shock, those people do very well with epinephrine. And the problem with epinephrine is it does have some alpha effect, but usually only at really high doses. So you have to, like if you're giving it in a code situation, for example, then you're going to start to see this breakthrough alpha effect. And so again, dobutamine, we don't use that often. And milrinone is another inotropic drug that we use. It is, if you're getting into the situation where you're adding dobutamine or milrinone, chances are you're going to need to have someone come in and give you a hand. You might be talking about a pulmonary artery catheter or something like that, okay? So again, milrinone works actually on the cyclic GMP system, and it's a sort of subcellular kind of drug that increases inotropy, but it can drop your blood pressure. It's really good with people with failing hearts, but it has some really very specific sort of reasons to be using milrinone. Vasopressin is very important. We talk about it a lot. We don't use it quite maybe as often as we should. This is really just telling you that normal levels of vasopressin, what happens when you start to go into shock, you deplete your vasopressin, your endogenous vasopressin really fast. So where does your vasopressin come from? It comes from your pituitary. So what happens is you go into shock, you dump your vasopressin because it's a reactive sort of a reflex for your body, but then it starts to drop, right? So shock is going on, worsening shock is going on, and you lose the vasopressin. So if you look here at vasopressin concentrations, this is an old study here looking at AVP vasopressin concentrations in different kinds of septic shock, cardiogenic shock. Look what happens in septic shock. You have no vasopressin left. Okay, so if you actually took pictures of the pituitary, you see that all the granules, and this doesn't project very well, but you see that the pituitary has degranulated all of its vasopressin. So vasopressin is really important. We don't think about it that often, but it works on vasopressin receptors. So when you're going to high-dose drugs, and you've already saturated all the receptors you've got, then you've got to start thinking about, well, I've used up all my alpha receptors, and so what am I going to do? I got to add something else. So adding something that works at a completely different receptor can be really helpful, and that's where vasopressin comes in as a really useful second or maybe third line agent. However you define, first, second, and third line, a lot of this is judgment call, even though there are specific guidelines for this. So remember that vasopressin is probably underused, especially in septic shock, and it's really helpful. Usually we started at one dose, we don't titrate. Okay, so the dose is not a titratable dose. Epinephrine, once again, we usually talk for myocardial depression. It's inotropic support, and it's also heart rate support. So it's a chronotrope and an inotrope at the same time. It can be very detrimental if hypovolemia is not corrected. And then if I'm adding epi or milrinone or dobutamine, I'm generally putting in a pulmonary artery catheter, okay? So I'm starting to get to that point where I'm starting to think, well, this isn't just pure hypovolemia. It's not just pure volume. It's not just pure vasodilation. I'm now looking at a failing heart, and I need to add something more, okay? So at that point, I'm looking for more information. Now, sepsis affects the heart, okay? So in septic states, you actually have a drop in your cardiac output. So what happens is, as you go into shock, your cytokines actually cause a cardiac dysfunction. And so you see this at the subcellular level, but also at the receptor level. And what happens is this cardiac dysfunction actually starts to drop ejection fraction. And remember what I told you about warm shock and cold shock? Remember how we talked about the different kinds of shock states? And when you started to talk about your cardiac output and your SVR, it was variable depending on the shock state that you were in, even though you were in septic shock. The early shock was hyperdynamic. The late shock was hypodynamic. Well, one of the reasons for that is because the heart isn't working so well, and it's been affected by this. So you actually see a drop in your left ventricular ejection fraction as shock goes on. So again, sometimes it's necessary to support a failing ventricle in a septic shock state, not just in a cardiogenic shock state, because once again, as I told you before, even though we have categories for shock, there's a lot of overlap. Okay, there's a lot of overlap between hypovolemia and distributive shock, and now you see the overlap between cardiogenic shock and septic shock as well. So it's not always like pure, absolute black and white. Sometimes it turns out to be gray. And this is one of the reasons. You know, somebody goes into septic shock, frequently they come to the ICU and they have an elevated troponin level. And then they also have an elevated BNP level, okay, because their heart has been poorly affected. Now, again, a little bump in your serum troponin level is probably expected in all your septic shock states, but once it starts to get to a certain level, now, of course, what it shows is that that person has been maximally stressed, and now they're starting to rule in potentially for a non-ST elevation or potentially an ST elevation myocardial infarction from the tachycardia and the hypotension and the coronary hypoperfusion and the hypoxia that all come together where the heart has been working really hard but didn't get enough substrate delivery, i.e. they were in shock, right? So here it is. So a little bump in troponin level is probably normal. How much is normal? I don't know. And a little bump in your BNP looking like they're in congestive heart failure even though they're not, because once again, you've got a slightly failing right ventricle. So the whole thing starts to come together. So again, if you're going to be looking at these markers, they're good biomarkers, but always take all the information you get in the context and with a grain of salt, okay? Nothing is ever as simple as it looks, okay? Unfortunately, that's the world of critical care, and that's why, you know, it's nice to have, you know, friends and colleagues that you can go to for information and guidance. So again, you know, so here's initial resuscitation of septic shock. Consider inotropes in low cardiac output states. Sometimes we even add steroids, okay? How do steroids work? This is one of my board questions for my anesthesia boards, by the way. I won't tell you what year, but it's a long time ago. It was the last question. I was sure I failed the boards because I said, I don't think there's an answer to that. And so the answer is that we now believe that they potentiate the action of catecholamines. So you give steroids, and they actually potentiate the action of catecholamines. So if you're giving epinephrine or norepinephrine, and you give someone steroids, they actually augment the ability of those receptors to respond to those catecholamines. They're also, by the way, they're very important in themselves, right? They're part of the hypopituitary adrenal axis, right? So again, you know, if you're hypopituitary or hypoadrenal, you're going to be in a distributed shock state all by itself, so you're overcoming that. Again, you know, we talk about depletion of vasopressin. People also deplete their cortisol levels as they get sick. So sometimes it's decent judgment to go ahead and give steroids for patients in septic shock where they're not responding to fluids or vasopressors. So we talked a little bit about transfusions. And transfusions, basically, we tend to give blood because why are we doing this? Because once again, go back to the equation, right? The important equation. It talked about increasing the hemoglobin, which was one way of increasing oxygen delivery. So if people are getting really anemic, it could be that they're bleeding, but it could also be that we've poured so much fluid into them that now they've got a dilutional anemia and they need to be resuscitated. You need to increase the oxygen carrying capacity of the blood, and so therefore giving them some blood may not necessarily be a bad idea, okay? So again, you know, I tend to push their hematocrit closer to 30%. The guidelines will say closer to 7%. I'm allowed to have my own opinion on this. So target glucose less than 180. Why is that? Because above 180, bad things happen. 180 is the renal threshold at which most normal kidneys will begin to spill glucose into the urine. And therefore, you've got some great urine output. You've got an osmotic diuresis going on. By the way, it's bad for the cells. And the urine output looks great, but the patients are actually getting more dehydrated even though you think you're filling them up, okay? So it is an osmotic diuretic. That's why we try to keep the glucose under control. And then bicarbonate is usually not recommended when the pH is greater than 7.15. Remember, I told you right about there is where the receptors change. However, I tend to use a bicarbonate of 16, and I tend to be a little bit more liberal with bicarbonate. I think, you know, bicarbonate, first of all, it's a hyperosmotic fluid. So it pulls fluid back into the vasculature for a little bit of time. It also helps to get you above this threshold here so the receptors are optimally working. And so I think it has a number of good beneficial uses. However, you've got to be judicious. And sometimes you've got to be careful because bicarbonate turns into CO2 and water and salt when you give it into the intravascular system. So you've got to be able to compensate, especially if people are getting large doses of bicarbonate, so you don't turn a metabolic acidosis, which we'll talk about in a little bit, into a respiratory acidosis. And that's why bicarbonate was taken off the ACLS algorithm, because people were bagging at the same rate, and meanwhile people were pushing in bicarb, and all of a sudden their PCO2 would go sky high, but we weren't blowing it off. Okay, so that's the reason it got thrown off the algorithm, because it was actually causing some problems. Now, if you compensate for that and you have a compensatory hyperventilation while the bicarbonate is going in, you might be doing some good, okay? So again, a lot of this is judgment, and a lot of this is kind of like, what's the secret sauce, right? Everybody has a slightly different way of making the secret sauce, but usually it ends up pretty well in your particular hands, in your particular taste. So steroids, I mean, if you actually look at the curve here, the forest plot, you see that this is the line of unity, and look at all these trials looking at steroids. Well, they're darn close to the line of unity, so the data is kind of not so good about steroids, but if you really kind of want to make a case of it, more of it goes to the right than to the left, and therefore you have some potential favoring of steroids in septic shock. So again, if you're thinking about it, patients failing, steroids may be a reasonable alternative, and it is in fact supported by some evidence. And increasingly, the pendulum swings back and forth on steroids every about 5 or 10 years. So depending on what cycle you're in, you might be using it. Interventions in managing shock, going back, fluids, vasopressor, vasodilator, we don't usually use anymore. Cardiac output, fluids, contractility agents, vasopressors, hemoglobin, supplemental oxygen, mechanical ventilation, and then cutting back on oxygen demand. If you can increase luxury perfusion, i.e., there's more oxygen going than is actually needed, even though your oxygen delivery might be somewhat limited, by decreasing oxygen utilization, i.e., sedating the patient, controlling fever, managing anxiety, things like that, managing shivering, these things will all push the oxygen demand part of the equation in your favor. So therefore, you're changing a critical oxygen demand, a very marginal oxygen luxury, into a more luxurious situation where you have luxury perfusion by actually sedating, controlling fever, managing shivering. These are all important ways to decrease oxygen consumption in the setting of a fixed oxygen delivery. Does everybody understand that? Okay. Once again, if I talk too fast, I want people to tell me. My wife says I talk too fast, and so I got to be careful about that. So anyway, so this is kind of like my algorithm. I put this together, and I don't expect everybody to use it. But basically what I'm going to do is I'm going to start off with crystalloid. I may give some blood, depending on whether it's needed or not. And I'm going to start off with, some vasopressors, especially at this level here when I'm giving some crystalloid. I'm going to start with some norepinephrine. And then I'm probably going to add a little vasopressin. Now I'm starting to get into the situation now. I'm adding a third pressor. I might be thinking about some colloid, maybe or maybe not, depending. And then, if I'm getting into a situation here where things are still not responding, I'm thinking about problems with inotropy, and I'm thinking problems with cardiac output. So at that point, until now, it's been really good. I've had my CVP line in. I'm measuring CVPs and arterial catheter, and I'm measuring my blood pressure. Maybe I've added a Flotrac. Now I'm getting into that third line vasopressor. I'm thinking about what am I going to do next here. At that point, I'm thinking about putting a pulmonary artery catheter in, and at that point, I'm putting a patient on epinephrine and steroids. Okay, so again, it's kind of like escalation of therapy, right? So again, there's no secret formula to this, and everybody's going to look at this a little bit differently. But if this, someone holds a gun to my head, this is what I'll come up with. This is how it works in my world. Okay. So again, sepsis biomarkers. Procalcitonin is very, very helpful. If someone looks septic, they may not be septic. The caveat here is that procalcitonin is a biomarker that's really good for the diagnosis of bacterial infections. It's not really good for the diagnosis of fungal infections or viral infections, okay? Only really works for bacterial infections. But somebody could be coming in with a bacterial pneumonia, and you're not sure if this is a bacterial pneumonia or a viral pneumonia. You send off a procalcitonin level, and now your differential diagnosis is shifting a little bit more to the side of actually having a bacterial pneumonia, for which you want to begin empiric antibiotics. Not to say that you shouldn't be giving empiric antibiotics in someone with a viral pneumonia, because sometimes you get viral priming of the mucosa in the lungs and so forth. They get a superimposed opportunistic pneumonia on top of a viral pneumonia. But again, the procalcitonin is something that can help guide you in the right direction. And it's pretty easy, it's pretty cheap, and I think we can get it back in a couple of hours. So it's just something to have out there as another piece of useful information in your armamentarium, okay? So again, the procalcitonin level will go higher and higher the closer you get to true septic shock from a bacterial source. We talked a little bit about this. We talked about the hints in the CBC, the dual bodies, toxic granulations, and vacuolization. Once again, they're defects in granulocytopoiesis. And just like a left shift, the presence of toxic neutrophils, it means that endotoxemia is causing a real mess in the white cell production system, okay? So again, just kind of look for these little clues. And, we frequently ask our medical students and our PA students in the ICU, what does this mean? And, most of the time they really have not, it's not even on their radar screen. So just think about these as things that you can look for because your differential will kick this whole thing out. Just look for it. It's in the bottom of your differential, and it's very helpful clues as to where you are in terms of the big scheme of things. Bandemia, once again, is a really important prognostic indicator. There are immature forms of neutrophils. So elevated bands with leukocytosis is bad, but like our presenting patient showed, elevated bands with leukopenia is very bad. So again, if you start looking at the probability of death, if somebody comes in with moderate bandemia of 11 to about 20%, their odds ratio of death is about 3.8. On the other hand, if they come in with high bands of greater than 20%, that adjusted odds ratio for dying is double. Okay, so our patient had a 38% bandemia when they came in. You know that you can risk stratify that patient into a very bad place right off the bat. Yes, ma'am. Yeah. Right. And they were viral pneumonias. Right. Which is sort of, again, it's very interesting. We recently got consulted on a patient who'd been septic for quite some time, and what happened was they were being treated, they were being not treated. We couldn't figure out what was going on, and the ICU team was called and just basically said, send off a procalcitonin, and it came back normal, and the patient was clearly septic. And it turned out the patient was really fungemic. And within about 48 hours of beginning antifungal medication, this patient defervesced. So once again, the specificity of procalcitonin for bacterial infections, I could not tell you the exact number, but it is highly sensitive and fairly specific for bacterial infections alone. Yes, ma'am. These are all really good questions to look up the answer to or talk to your pathologist about. I do not know the answer to that. I would believe that if you have someone who looks septic, on your first presentation, you send off a procalcitonin level, it comes back high, that patient has bacterial sepsis until proven otherwise. Now you just have to look for the source. Okay? Hopefully that's a good answer. Okay. Anyway, so again, in hospital death, okay, once again, really high predictive value odds ratio of bandemia to correlation with death. Okay, so again, bandemia is a very important predictor not only of positive blood cultures, but also for in-hospital mortality. So we're once again using it to risk stratify these patients for bacteremia and probability of sepsis and ongoing probability of death. Inflammatory triggers can come, as you mentioned, from the back over there, the lady just mentioned, is basically they can come from a lot of different ways. They can be parasitic, viral, they can be fungal, they could even be traumatic. Somebody who comes in a pancreatitis, for example, they look very septic, and at the same time, they don't actually have a bacterial infection yet, okay, until they develop potentially a phlegmon. So you have these situations where you've got this sort of overlap between sepsis and what we used to call systemic inflammatory response syndrome. So systemic inflammatory response syndrome, it goes in and out. People talk about it, and you say, well, the purists will say, well, we don't use that anymore. And the fact is it helps to tell if somebody's sick, okay? I mean, I'm sorry, you can't argue about that. If somebody comes in and they've got temperature, or if they're hypothermic, especially older people, or people who are immunosuppressed come in hypothermic when they're really sick, okay? So be looking for that as a marker for really bad sepsis. And so again, if they come in tachycardic and they're tachypneic, or their PCO2 is low and they're breathing fast, these people are sick. So white count really high or white count really low. So they could be they could have a leukocytosis or they could be leukopenic. Both ways, they're going to be very, very sick. So even though we don't use systemic inflammatory response syndrome much anymore, it's still out there as a way to identify sick people. And this kind of makes sense because in the olden days, right, we used to look at the 4 cardinal signs of inflammation, and 5 cardinal signs of inflammation, I'm sorry. So the heat, redness, swelling, pain, and loss of function. So again, if you go back here, these actually correlate with the systemic inflammatory response syndrome, right? So they are part of a sort of a continuum where people are moving on this sort of old line through this. This was the old sepsis continuum, where they came in with systemic inflammatory response syndrome, then they found an infection, then they had end organ damage, and then they were hypotensive and they were severe, they were in septic shock. But the new continuum is really severe sepsis has to be defined by hypotension. We're not going to go ahead and start defining, splitting these things, but once again, this is how we proceed through sepsis. So what happens with sepsis is what makes sepsis bad, and I'm going to spend a little bit of time on this, but you'll see it in a number of different slides. I'm going to repeat myself a couple of times. That what happens is when you start to get into systemic inflammatory response syndrome, what you see that shock triggers this. And also, systemic inflammatory response syndrome is really a marker for shock. So you can have cardiogenic, hypovolemic, anaphylactic, but these are all basically starting mediator release, cytokines, tumor necrosis factor, interleukins, free radicals, basically these kind of things that start to activate, endothelins, and you start to have vasomotor relaxation, you start to have leaky capillary syndrome, you start to have tissue macrophages accumulating, increasing the protein content of the extracellular fluid, sucking fluid out from the intravascular space, causing worsening of the hypovolemic state, and so you start to move into shock. And so you see all these little things which you can read for yourself. But what happens here is this moves into something called multiple organ dysfunction syndrome or multiple organ failure. And the idea here is to intervene while you still have a chance. By the time you get into cardiovascular dysfunction, lung dysfunction, GI dysfunction, transaminase elevation, liver dysfunction, and all this other stuff, you are starting to go down a very bad road. And the way that this works is basically I will just spend a little bit of time just going back over this. But what I'm trying to say, in the interest of time, is that the sooner you intervene, the less likely the patient is to progress to multiple organ failure. Okay, and how do we actually go to define that is something called the SOFA score. Okay, and we actually have talked a little bit about the SOFA score, but I'm going to go back here. We talk about what happens here as being sort of silent and subclinical, but what's happening here at the subcellular mitochondrial level, these folks are already in big trouble long before we realize it. So actively resuscitating someone in the shock state prevents you from going back into this multiple organ failure kind of cycle. So again, this is really important. And so once again, what happens at the subcellular level ultimately becomes manifested at the organ level, and that's when we talk about organ failure. So first we see tissue hypoxia, and then what we see is mediator storm at the tissue level, at the cellular level, and then that ultimately becomes a sort of an organ level failure, and ultimately becomes a failure of the organism itself. The patient crashes, okay? So it starts out as something that we barely even recognize early on. So as you see, the initial insult moves here, you get the trigger, you get these mediators and biomarkers, and they're all here listed for your entertainment. But what happens is all these things cross-connect, and what you see is that this is a situation where all the tissues that are being perfused are now being hypoperfused. And think about it. These folks come in with confusion, right? You see people getting agitated. You put the non-rebreather mask on, the first thing you do is tear it off, right? So they're starting to get combative, okay? That's a sign that the brain is not getting enough oxygen flow. Okay, the respiratory distress is coming because now all of a sudden they're becoming hypoxemic, they're shunting, they're getting into trouble. And cardiovascular shock begins to ensue. They drop their blood pressure, their perfusion pressure is dropping even further. They start to develop oliguria or anuria. And if we're measuring their urine output and their urine output is dropping, well, those kidneys are so smart, they know that the cardiac output is inadequate for them to make urine. So the urine output is such a great indicator of the patient's cardiac output that many times it's overlooked, okay? So again, it is a sign of a specific organ system failure. And so what we see is, gut translocation. We see bacteria moving from the inside of the gut to the outside of the gut. That's how people end up with line infections with enterococcus, right? Because they had to get there somehow. It probably didn't happen when they were putting the line in. More than likely, it's a failure of the barrier function of the gut in the setting of hypoperfusion and ischemia, where the bacteria were able to translocate and find their way outside from the inside of the gut into the bloodstream. First into the lymphatics and ultimately the bloodstream. So once again, the loss of barrier function is very, very important. So shock is inadequate substrate delivery, lactates the biomarker for shock, and this is what happens. The tissues start to fail. In the interest of time, once again, I'm going to start moving a little faster, but again, what happens here is you get the mediator release, you have these things, you have cerebral dysfunction, you have fever, or you have the lack of fever, which is also a very bad sign. You have this acute lung injury causing hypoxemic respiratory failure. You have hemodynamic collapse from the increased permeability and the vasodilation, once again causing hypoxic respiratory failure primarily because of some shunting at the microcirculatory level. Then you go on to develop acute renal failure because you're underperfusing your kidneys. Then what happens here, you start to have this kind of diffuse damage that is actually going to affect your coagulation cascade as well as your liver, so you end up with a coagulopathy. Many of these patients, interestingly enough, come in with weird D-dimer levels. They come in with strokes, all right? They come in with a blood clot somewhere. So again, they could have a procoagulant effect or a hypocoagulant effect, and it's unclear which one of these COVID seems to be implicated in right now. I have some friends at Emory University who run the stroke unit there, and they're saying so many of the stroke patients are coming in COVID positive. And they're just wondering if there's some kind of, we know that inflammation causes bad things. Anybody here work in the CT ICU, you know that people who have gingivitis and don't take care of their teeth have chronic inflammation, and those patients seem to have elevated risks of myocardial infarction because of the inflammatory cascade. The same idea seems to be applying to some of the viral syndromes we're seeing now, but the data is yet unclear, okay? So it's not quite clear yet. So this is the SOFA score that we talked about a little bit earlier. It's the Sequential Organ Failure Assessment Score, okay, SOFA. And what happens here is you start to look at all those systems that we talked about failing during sepsis and septic shock. So we look and see that, respiratory, coagulation, liver, cardiovascular. And so we use this to build up a scoring system from 1 to 4 for each one of these organ systems. So you have 1, 2, 3, 4, 5, is it 6? 1, 2, 3, 4, 5, 6. 6 scores, 6 organ systems, and 4. So the maximum score you get is 4 times 6 is 24. So the closer you get to 24, the higher your risk of death. So again, you start to look at these indicators, and you can use the cutoff numbers to risk stratify your patient. Now, whether or not this is a good score to use when you're triaging someone, I go back to that again, is highly controversial. But it is one way of risk stratifying someone when you first see them for potential triage. Okay, this gives you an idea of how bad their organ system failure is. So let's take this one, for example. If your PO2 is great, you get a score of 0. On the other hand, if you start to get into lower and lower PO2s, which is really the PF ratio, which is the PO2 divided by the FiO2. So the FiO2 can never be greater than 1, right? So the PO2 is let's say, for example, you have a PO2 of 76 on an FiO2 of 1. That's a PO2 or PF ratio of 76, right? So if you have a PO2 of 80 on an FiO2 of 0.5 or 50% oxygen, then that is a PF ratio of 160, right? So you see how these numbers kind of intertwine. So you use both the FiO2 and the PO2 to come up with this scale, and you can risk stratify these patients as to how critically ill their lungs are. We do the same thing with the CNS score. We use the Glasgow Coma Scale as a surrogate to find how their CNS function is in the setting of sepsis. And of course, the better their Glasgow Coma score is, the lower their score. So again, if they're comatose, they're going to have the maximal score possible on the SOFA CNS. The same is true for cardiovascular. And again, this comes from a lot of different stuff. This comes from the Society of Critical Care Medicine and a variety of international consensus statements. So people are still using dopamine in some places. We don't use a lot of dobutamine. But basically, the more dependent you are on vasopressors, the higher your SOFA score is going to be. So again, it is another organ system. Hematology, looking at your platelets. What are the causes of thrombocytopenia in the ICU? Well, you have medication-induced thrombocytopenia, you have dilutional thrombocytopenia, you have consumptive thrombocytopenia, you have multiple reasons for somebody to be thrombocytopenic, but in the ICU, septic thrombocytopenia is very, very important. A lot of people don't need to be tested for HIT all the time because they truly have septic thrombocytopenia, and it causes this sort of coagulopathy, if you wish. And so again, as your platelet levels are dropping, potentially your SOFA score is higher. Looking at the renal score, once again, looking at your creatinine levels, as you go further and further into acute kidney injury, the higher your SOFA score is. And so again, there's some other things that you can use in terms of kidney function that don't have to necessarily impact on the SOFA score, but I just wanted to work it in here that if you're pre-renal, your BN creatinine ratio is going high. There's a lot of reasons for your BN to creatinine ratio to be going high. It could be you have a GI bleed. It could be on steroids. It could be on TPN. But in the setting of oliguria plus a rising BUN, your kidneys are underperfused, okay? You are pre-renal azotemic. So again, these are things that you can do, and you can actually measure things like the fractional excretion of sodium. So you've got to work on saving the kidneys. Once again, saving the kidneys is a matter of fixing the sepsis cascade, making the preload sufficient, so that the heart can pump blood to the kidneys and prevent acute kidney injury. Why? Because if you look at sepsis plus AKI is a 70% mortality risk right off the bat. So the two of them together, we work really hard to pound the kidneys with plenty of fluid, maintain urine output, because if you fall behind, this is why in the ICUs, people have hourly urine outputs. And we are religious about following those hourly urine outputs because as they start to drop, maybe 1 hour by itself doesn't mean a whole lot, but now they're oliguric for 2 or 3, 4 hours, then they are in big trouble and somebody should be doing something about it. Okay, so once again, part of the resuscitation, we will be talking about catheterizing the bladder in a little while. So again, higher mortality risk. So what happens with SOFA scores alone? The higher the SOFA score, the higher the mortality. Duh. Okay, you don't need graphs to show you this. The more organ systems that are failing, the worse the patient is going to do. And as you start to look at the mortality here, by the time your SOFA scores are up in the 16 range, you're looking at almost 90% mortality. And that is very, very significant. So if you're talking about dicing the cucumber, you have to start thinking about how it is you're going to risk stratify these people to put them in the acute box for whether or not they might be candidates for ICU admission, candidates for appropriate, mechanical ventilatory support, or maybe some family discussions, okay? So this is, again, part of the way that we're approaching the situation here. Just another score and mortality slide. The thing I want to show here is this is the delta SOFA. So what happens is you start off with a certain SOFA number. As you progress, sometimes the SOFA score begins to rise and your mortality begins to acutely rise. Remember I talked to you about clearance of lactate? Well, what happens is your lactate clearance is a positive prognostic indicator. Your drop in your SOFA score is a similar prognostic indicator because what it allows you to do is to see how quickly that patient is recovering, if at all. Okay, so again, it is a very, very useful guide to just, even if you're not necessarily charting it, you're actually using it in your head to see how patients are progressing. So this is what happens with multiple organ dysfunction, that basically you have this tissue injury going into inflammation. In normal situations, you have inflammation balanced by anti-inflammation, which is a normal homeostatic state. So again, minor inflammation kind of comes and goes. You get this first hit inflammation, which potentially causes an activation of your cascade, if you wish. And then potentially, this is when you come in with a viral pneumonia. This is your second hit. You become hypotensive. You have gut translocation. You have a second organ system failing. You have a superimposed pneumonia. You get an aspiration when you're intubated. You get a second hit that goes on and starts to really push that inflammatory cascade. And what happens at that point is you go into this multiple organ failure syndrome and death. There's also something called quick SOFA score, which many people don't believe in, but it's respiratory rate, blood pressure, and altered mentation. So again, critical care and resuscitologist, I think this is really important. This is a very simple slide, and this slide tells you so much. Okay, what happens here as the disease severity begins to worsen, okay, your intensity of resuscitative efforts need to be in parallel with that disease state. And that is what makes the ICU very different from many other places, that we are able to initiate these heroic interventions very soon. If you fall behind, things will not go well, okay? And that is exactly what we have to do as we resuscitate patients. We're pushing really hard. So if you look at the phases of resuscitation, when I first got here, people got really upset with me for giving Lasix in the ICU. And the thing is, well, wait a second, there is a time to give Lasix. What does the formula say? When do you give Lasix? Well, when you've gotten through this point of rescue and optimization and you've stabilized the patient, you've fixed the lactate level. The blood pressure is pretty good. The heart rate's okay. Now you've got to de-escalate. If you wait for the patient to clear 30 liters of fluid or 60 liters of fluid that you gave them during the active resuscitation phase, then that patient will be there forever and they'll get millions of complications. On the other hand, if you go ahead and you start to rapidly and forcefully de-escalate that, it is so important. So what happens here is that you've got to be able to track the de-escalation and support that de-escalation appropriately as well, not only just tracking the escalation on the upside of things. So I'm going to talk about this lady here, a 45-year-old with malaise and lethargy. Her vital signs show a heart rate of 145. Her blood pressure is still pretty good, 110/80. Her respiratory rate's a little bit high. Her SAT's 98 on room air. She's becoming more tachypneic and anxious during the evaluation. Anybody have any issues here? She's tachycardic, right? I mean, that's the only thing we got so far, but it doesn't look right, okay? So we got to think about why she's tachycardic. Did she forget to take her beta blockers for the past 3 days? Is this beta blocker rebound or abstinence rebound? So what should we be doing? Should we start to monitor this patient? Anybody want to put this patient on a floor? Anybody want to put this patient in a monitored setting? Anyone want to admit the patient to the ICU? So no takers on the ICU, no takers on the floor, but definitely monitored setting is the consensus I'm getting here, right? And that's important because now you've taken a look, you've assessed this patient, where to go next, okay? So and what are the goals of monitoring? So we get some vital signs a little while later, and now her heart rate's a little bit better, 136, her blood pressure's about the same, respiratory rate's going up. It's almost 30, okay? She's a little febrile, her stat's beginning to maybe drop, she's now on nasal cannula oxygen. So we decided to do a blood gas. The blood gas comes back at 732, PCO2 of 32. We'll talk a little bit about this more in a little bit. And her PO2 is kind of a little bit on the low side. Her labs come back, and what we see is her sodium's 142, her bicarb is 16. She has kind of an acidosis. Her BUN's a little bit elevated, her creatinine's a little bit elevated. We don't really have baseline data yet, okay? So anybody worried about this? Yeah, so we got a little tachycardia, and we got a little bit of acidosis, maybe a little bit of pre-renal azotemia developing, right? Blood pressure's still fine. So what are we calling this state? Compensated shock, exactly. So she's still in a situation that she is in compensated shock. So this patient here, if we do not intervene at this point, she will get worse, okay? So again, so her blood pressure now starts to drop, okay? So her blood pressure is 88/40. Heart rate's still what it was. Respirations are now 32. SAT's really, she's now on a non-rebreather mask, SATing 90%. We get a lactate level, comes back 4.2. What do people say about this? Where do you go now? Yeah, now she's in shock. Okay, the lactate is a biomarker for shock. Okay, so she is now developing tissue hypoxia. She's also hypoxemic, right? And what happens is she's starting to evolve respiratory distress because she's certainly not going to breathe that fast for so long. And at this point, she's beginning to drop her blood pressure, and she's still tachycardic. Hopefully, by this time, you would have sent off a lactate, you would have started a fluid bolus, and you probably would have given some empiric antibiotics, and maybe you're starting to think about maybe adding some pressors. Anybody want to send this patient to the ICU right away? Or do you want to manage this floor on the floor telemetry setting for a little bit longer? Okay, I got about 50-50 there. I guess it depends on your ICU. Some people will say, hey, let's resuscitate this patient, see how she responds to more resuscitation, and maybe that's a possibility. But on the other hand, I think the writing's starting to get on the wall here, and this patient is going to crash, okay? So again, I think, pessimist sees the difficulty in every opportunity, optimist sees the opportunity in every difficulty. This is an opportunity to make a difference. So I'm going to go into, we won't do this one so much. I basically going to blow through this a little bit, PPE and resuscitation. I think a really important thing here is to have a communication strategy. If someone's coming up to the ICU and you think they're COVID positive, make sure the ICU knows. Okay, make sure they go into the right room. Okay, And the thing is that do not keep things secret. If you're thinking that somebody might be COVID positive, let us know. And the other thing is have a transportation protocol. And I think all this stuff is being developed here already. So let's go on to fluids and electrolytes. Fluids, we talked a little bit about the Starling curve already. You give more preload, the cardiac output goes up. So what happens is if you don't want to change the preload, but you want to increase the cardiac output, you add an inotrope, like epinephrine, okay? So an inotrope increases the cardiac output at any given level of preload. Or on the other hand, without an inotrope, you can increase the preload and increase the cardiac output by increasing the filling pressure, recruitment of the heart, and also potentially increasing the inotropic state. So here you are, you go ahead, you increase preload, and the cardiac output goes up. Once again, we're talking about swelling, which is the cardinal sign of inflammation, and fluid is moving into the third space. What is third space fluid? Okay, it's fluid that's not intravascular, it's not it's not technically extracellular in the sense that it's not recruitable. It doesn't come back, okay? So what happens is this is inflammatory fluid. It goes into the third space and it stays there because the inflammatory mediators and protein and the cells in there are actively keeping the fluid in the interstitial space, and it does not come back in. Under normal circumstances, somebody gets dehydrated, the cellular fluid replenishes the interstitial fluid that comes back into the intravascular space. On the other hand, when third space fluid goes out, it doesn't come back in until the inflammatory state has been resolved. And that is really important. So you're filling up a lot of third space fluid. The peritoneum has a massive surface area. If you were to lay out the peritoneum of a 70-kilogram normal person on a tennis court, that peritoneum would just about cover the entire tennis court. 1 millimeter of swelling in that peritoneum is equivalent to, let's say somebody comes in with a chemical peritonitis, like a biliary leak, or somebody comes in with a perforated viscus, and they get a little tiny 1 millimeter swelling of that large surface area peritoneum. Anybody got an idea how much fluid we're talking about? Just to get you back to zero? Pick a number. 5 liters? 10? 15? 20? Okay, take 20. I take 20. It's 20 liters of fluid, okay? Just to get you back to the euvolemic state that you were in before you start to have third space fluid into that peritoneal cavity. So people talk about, man, the surgical ICU, wow, how much fluid are these guys going to give? Well, we're giving lots of fluid because you got to replenish the intravascular space, because it's only intravascular fluid, not total body fluid, that affects preload, that affects cardiac output, which affects oxygen delivery. You guys following that? Anybody not follow that? Okay, that's a tremendous amount of fluid to get you back to point zero. Okay, so that's third space fluid, and this is why it happens, because you have all this inflammatory stuff occurring there, and what's happening, you're building up all this protein, and the protein is actually an osmotic force and sucking fluid through leaky capillaries into the interstitial fluid, into the interstitial space. And that is why you have the combination of leaky capillaries plus the osmotic gradient favoring the sucking of fluid from the intravascular space into the inflamed extracellular space. Okay, that is what's happening. So again, this is capillary leak. I'm not going to spend a lot of time on it. It's in your handout. So we're going to talk a little bit about IV fluids. There's 3 different kinds. There's hypotonic fluid, like D5W, for example. There's hypertonic, like hypertonic saline, and then there's isotonic fluid. If you are going to resuscitate someone with hypovolemia, which one of these, or which is the preferred one of these that you would use? Isotonic. Okay, so that's right. This is classically, traditionally what we would use, okay? Now, I will tell you that the folks in the DOD would much rather carry around a bag of hypertonic saline, because it increases your intracellular, it increases your intravascular volume so much more by sucking fluid back in for a short period of time than they would carry around 3 bags of isotonic fluid. Okay, so the DOD in fact is using hypertonic saline for resuscitation in the battlefield. This is not a battlefield, and we're not going to dry out the intracellular milieu, if you wish. We're actually going to use isotonic fluids. Give me isotonic fluids. Normal saline, lactated ringers. Okay, those are the 2 that we generally use here. Okay, So again, this is what's happening. If you have hypertonic fluid, you're basically sucking fluid out of the cells, but you're bringing it back intravascularly. We like to do this in the neurocritical care unit because it actually shrinks the inflamed brain. On the other hand, if you give a hypotonic fluid, what's going to happen is that water is going to leak all over the place, and it's not going to stay within the blood vessels, and you've got no preload recruitment. So giving D5W or D5 half normal saline to someone who's hypovolemic is not going to get you very far. So that is why we use isotonic fluid that repletes the intravascular space more effectively. These are the numbers. There's a little bit of potassium in lactated ringers. By the way, is this potassium enough to make you think about renal failure? Somebody's in acute renal failure. Do you have to worry about that amount of potassium? No. Okay, good. Okay, that's really important, okay? So sometimes it's important to mix up lactated ringers and normal saline so you're not over-chlorinating someone. Chloride is kidney toxic, by the way. So you've got to be careful more. The higher the chloride, the faster you're going to kill the kidneys. But the thing is that this amount of potassium in lactated ringers, you would have to give 10 liters of lactated ringers to give that patient 40 milliequivalents of potassium. So you're probably not going to do that all at once, and things will shift and things will work out for most of the time. But you don't want to stay clearly on one. You want to be moving back and forth between lactated ringers and normal saline. So again, the chloride in normal saline is very significant and causes a hyperchloremic metabolic acidosis, and it is also nephrotoxic. Fluid compartments, I'm not going to spend a lot of time on this, but these are your extracellular fluid compartments. So once again, you've got a tremendous amount of fluid in the body, which if the patient comes in dehydrated and septic, you have got to restore this to normal operating conditions as quickly as possible. So I'm not going to say much more about this other than, once again, going back to the fact that in sepsis, what happens is you are creating a hypovolemic state. That hypovolemic state is dropping your cardiac output. The kidneys dropping the amount of urine that they make is directly reflective of that patient's cardiac output, and it is directly reflective or indirectly reflective of their preload. Okay? You can have someone going to acute kidney injury just because they have cardiorenal syndrome and their heart doesn't work anymore. That's true. But in a typically septic patient, not the CT ICU, you've got a situation here where you're really looking at cardiac output being reflective of preload in a septic patient. That is important to fill that back up and to watch very, very closely for the urine output. So we put a Foley catheter in. So the kidneys are smarter than all of us put together. INO is really important. Renal perfusion estimates cardiac output, and we're looking for half a cc per kilogram per hour. That is roughly what we're looking at. Does that mean if it's 0.4, I'm going to panic? No, but it means that I'm starting to think about it. I'm certainly not going to pull the Foley catheter out if the patient is progressing toward oliguria. Once again, we talked about this already, and I'm going to talk about fluid balance. This is important because a lot of times people talk about it and say, well, you overloaded the patient. Well, here's the funny thing. Did I overload the patient because I overloaded the patient and I was careless? Or did I overload the patient because the patient was so sick that they needed all that fluid? And what happens is that fluid overload is probably an indirect marker for how sick the patient was. I didn't overload the patient. If I had underloaded the patient, they would have gone to multiple organ failure syndrome. On the other hand, now I overload the patient and their fluid overloaded. Yes, it's true, but the fact is, and that has a higher risk of death, but it's probably not the fluid overload that caused the higher risk of death. It was the fact that they needed so much fluid that caused the risk of death. You understand? It's the way you interpret the data and make the argument. You guys following this right now? Okay, because a lot of times, I've talked to folks who say, well, the fluid, you gave way too much fluid. Look, the patient's dying. Well, the patient didn't die because they got so much fluid. They needed all that fluid, and that is a biomarker for how sick they were. So again, it's third space fluid needs decrease, cut your fluids, assess for diuresis if needed, right? You've already achieved what you need to achieve. High CVP decreases organ perfusion pressure as well, so you've got to be a little bit careful with that. And I'm not ignoring that point, but once again, usually those patients are needing fluid resuscitation, and those patients who ended up with total body overload most of the time never developed a high CVP as long as their heart function was normal. Okay, and that is the important take-home message here. Those people who do not respond, they have global increased permeability syndrome, or GIPS. those patients are extremely ill, and they're the patients that are probably not going to make it, okay? It is not because you made their, if their CVP is high, it's time to cut back. You've recruited your preload. On the other hand, if you continue to recruit preload, their CVP is not changing, and it's all leaking, that patient has global leaky capillary syndrome. Okay, so again, these are your phases of resuscitation, which we just talked about. So you've got to get to the point where you're beginning to de-escalate, and here is where the intensity of de-escalation matters, okay? So this is what happens. You have now escalated therapy, the disease severity, you achieved and maybe surpassed the disease severity. This is so important. Now you're going to get to the point where disease is now stable. The patient's peeing, their heart rate's down, their blood pressure is better, they're off vasopressors, they no longer have lactic acidosis, and all the sort of signs are starting to get better. At that point, you need to continually de-escalate your resuscitation in the same way that you were escalating it during the initial phases of resuscitation. Otherwise, the patient is going to be in the ICU forever, okay? So when I got here, and surgeons used to yell at me and say, well, what are you giving Lasix for? Well, in a large way, it was judgment call, and it was time to de-escalate, okay? And so we got to the point now where people understand this curve, and what we're doing is Lasix is no longer the devil's drug. It's only the devil's drug if the patient's not peeing, and you give a bolus of Lasix when they're hypovolemic, and then you really hurt them, okay, because they needed volume resuscitation, and you were focused on the urine output. That's when Lasix is the devil's drug. Lasix ceases to be the devil's drug when it's time to de-escalate, stand back, and move the patient out of the ICU a little bit faster. Do you all understand that? Okay, very good. All right, so goals of fluid management: maintain preload, cardiac output, substrate delivery, tissue perfusions to prevent secondary injury, and keep your electrolytes within the normal range, sugar, sodium, magnesium, and avoid too much edema. Let's talk a little bit about ARDS. Yes, Lou?
Different than somebody's in sepsis, right? If somebody is third spacing on a large abdominal operation, you don't necessarily flood them with fluid to keep that urine output up initially, do you?
So what I do is I don't necessarily flood them with fluid. So the question is that when somebody has a laparotomy, there's a time for permissive oliguria, and that oliguria is okay as long as you're watching it. And the fact is that so the question is that okay? Well, the question is, I think it depends, right? So that's what I learned in law school. The answer is always it depends. It's always C. So the thing is that the truth here is that if the patient comes in and they have a chronic renal failure, they're chronically on, they have a diabetic state, they have diabetic or hypertensive nephropathy, their kidneys are really sort of sensitive, right? So you have to think about making sure that you don't lose anything there. You want to make sure that, again, what is permissive oliguria? I would say if you fall transiently for a shift to 0.3, as long as you're watching, and again, maybe sometimes that does pick up, but usually the problem with laparotomies is that laparotomies tend to sort of make the tissues very angry because of manipulation and also the reason they had the laparotomy to begin with. And what happens is that third space fluid in typical situations begins to mobilize on day number 3. And sometimes that's a long time for the kidneys to wait. So I tend to be, again, this is me, this is my personal opinion. So I tend to be a little bit more aggressive, and I'll say, hey, boom, 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 I will give more fluid, I will bolus the fluid for this oliguria because I'm going to try to help the kidneys before they get into trouble. And I will go ahead and potentially give fluid bolus to get their renal output back to normal. And what I'll do is when their situation stabilizes, hopefully by 3rd day post-op, then I'm walking in with a syringe of Lasix, okay? So I'm going to be, I'm kind of like, I tend, it's not so much, it's a kind of a judgment call. So some of these patients, again, they continue to sequester for longer than 3 days. So again, the classical teaching is a half a cc per kilo per hour, plus or minus a little bit. But again, I don't think that there's a period of permissive oliguria for any true length of time. So what is it, a shift? I start to get nervous if it's a shift. Yeah, I'm at that point. So, but any other points or questions? I think, again, as long as you're following the patient really closely, but I think if the patient gets to the point where they become pre-renal, and then the pre-renal state leads to ATN, which is acute tubular necrosis, and you're starting to see maybe the development of a little early renal tubular acidosis, that's by that time you've lost ground, especially in somebody who comes in with potentially compromised kidneys at baseline. And again, it's the diabetic, hypertensive, nephropathies, or the medication-induced situations where you have somebody on ACE inhibitors, and they're a little bit vasoplegic, perhaps a little hypotensive. That sort of aggravates with the hypovolemia, and you've got this whole thing. So no two people are going to be exactly the same. But I think your question is very well taken, and again, I think as long as you're watching the patient and prepared to intervene and not letting the patient go too far down the wrong path, I think it's reasonable to think about that. But again, I tend to be, I'm in favor of let's get in there and give the fluid. I'm going to diuresis them later. Right, routine laparotomy patient, possibly a little bit different situation. I don't get to see those patients very often. It's usually the way it works in my life. Okay, yes, Dr. Vernkar. Yeah. Yeah. It's the second reason. So the question is it because lactated ringers has been associated with some early cellular apoptosis? That is the reason that I don't use lactated ringers exclusively. I don't think that's the reason why. I like the idea of following the chloride level very closely. So, if you watch CBS News about a year ago, it was flooded with news that, doctors are finally realizing the dangerous effects of chloride on the kidneys, right? So, and of course, it was actually in the literature. So there's a lot of data showing that hyperchloremia exacerbates renal failure. And so I tend to look at chloride as being toxic to the kidneys. I try to manage the two isotonic fluids in balance. The nice thing about lactated ringers is the lactate gets metabolized into bicarb. So if you've got somebody in a shock state and they have a lactic acidosis, that lactate, as long as the liver is working, then that lactate will also help as a buffer. Whereas in sodium chloride, the pH is a little bit different. The buffering capacity is absent. And so I think it's nice to be able to shift between the two. But it's a very good question because cellular apoptosis and lactated ringers, there's been a theoretical argument about that for some time. I don't think it's enough to change my clinical practice. Sure. No, Plasma-Lyte's fantastic. I used to use it in Pittsburgh all the time. When we were doing liver transplants, it was constantly Plasma-Lyte, Plasma-Lyte, Plasma-Lyte. I don't know why we don't have it here, but again, it's, again, we have been able to manage our sick patients without it. And I don't, I know the pharmacy has its constraints and so forth, but Plasma-Lyte's another alternative. The reason I haven't included it on any of my slides is because I know that it's not available within the system, therefore I left it off. Good point, though. Yes, Vic. Blood over fluid in the absence of blood loss. So I think in the absence of blood loss, once you start to drop your hemoglobin to the point that you're starting to interfere with oxygen delivery potentially, then I think about it. I tend to try to keep the hematocrit, it depends, right? So the guidelines, 7, okay, for hemoglobin. On the other hand, if someone has a bad heart, if someone is going to get more fluid and you're not going to be checking another crit until the morning, and you start off with a crit of 24, now you're going to give the patient another 6 liters of fluid by morning. The crit's probably going to be 20, you're probably going to be transfusing anyway. Why not increase the oxygen carrying capacity unless there's other restraints? The thing is we do also know that blood transfusions actually cause an allogenic change in immunity. Okay, so what happens is they actually suppress immunity. There's probably nobody in the room who's old enough to remember this, but when I was doing transplants, when we were doing kidney transplants, what do we used to give? We used to give FFP during the kidney transplant because we knew it depressed the T killer cell activity. And by decreasing T killer cell activity, it actually went ahead and prevented hyperacute rejection. This is more than you wanted to know, but in fact, it is something that is something that you think about when you give a blood transfusion that you might be impairing immunity as well. So just to have it there. Blood transfusions, by the way, have been repeatedly shown to potentially, how about that? That'll get me a YouTube moment. Repeatedly shown to potentially increase the risk of tumor spread during esophagectomies and chest surgeries. So what happens is during those surgeries, we do realize that if a patient gets a blood transfusion, the risk of metastatic disease is elevated. Has it been shown with other kinds of tumor surgery? Not so much. Anybody wants to do that, you can do the search. It's all over the literature. Go to the American College of Chest Physicians, fantastic review papers there, but it's all over thoracic surgery and everywhere else. So again, it does depress the immune system. Is that a good thing or is that a bad thing? So maybe these patients who come in with COVID are actually having a immune system raging out of control. Maybe if we transfuse those patients early, we'll depress their immune system. I don't know, that's like skying. That's really far out, way out there. There's no data to support that at all. But seeing as you brought it up, I'm willing to argue it with you. So, thank you. Yeah, there are NSAIDs, for example, I think are clearly contraindicated. So again, I think messing with the immune system is a really complex problem, steroids, because you don't really know what stage of immune response that patient is at. So I tend not to get into that too much. So again, immune modulators, we did that for a long time. We were looking at, interleukin antagonists and things like that, and that didn't work out so well. So, but it's a really good set of questions. Okay, so let's get into ARDS, because this will take us into mechanical ventilation, and I think what's going to happen is once we finish with this, we'll move right into the skill stations. There will probably be some extra stuff there for interpretation of blood gases, and I think those exercises are good, but I think we'll spend a little bit more time on ARDS if we can. So what's ARDS? ARDS is an inflammatory response of the lung. So what happens is, remember we talk about patients sucking up fluid and they get really edematous? The old words were they got to swell to get well. Okay, they were really sick, we had to swell them to get well. So you had tissue edema all over the body. So if you held up the patient to the light, if you had a really bright light, the tissues would look like ARDS because there's lots of water, right? There's lots of extravascular water in those tissues. But what do we have? We have the ability to do chest x-ray. The same thing is not true so easily for looking at other tissues. So we do a chest x-ray, and the chest x-ray begins to look like it's all fluffed out. And that's a reflection of the amount of extravascular water as a reflection of the ongoing inflammatory storm for the entire body, but we're looking at a chest x-ray, right? So it's just a reflection of everything else. So when we talk about pulmonary edema, it's very important that we make a distinction between cardiogenic pulmonary edema, that's because of heart failure, and those patients have pump failure, and what's happening is the left ventricle is not pumping forward, rather every time it pumps, it's really pushing some of the blood back into the lungs, or it's beginning to back into the lungs because the heart cannot push it further out. So either it's kind of a valvular function dysfunction, or it's a kind of an afterload dysfunction. That's why you put patients on ACE inhibitors. Or what we do is it's actually a cardiogenic state. It's the heart is not working. It's a hydrostatic pulmonary edema. The pressure is forcing fluid out through the tissues, through the capillaries into the lung. Because the CVP is really high, the wedge pressure is really high, the left ventricular end diastolic pressure or volume is really high, those patients are in cardiogenic shock. So what happens here, non-cardiogenic pulmonary edema, that's what we've been talking about. It's the leaky capillaries that are now reflective in the lungs, okay? So what's happening here is a cardiogenic pulmonary edema. What happens here is that this sort of permeability pulmonary edema is occurring because it's not so much that the fluid is being forced by high pressures. The pressures can even be low or normal, and it's still leaking out because of leaky capillary syndrome, okay? Does everybody understand it? This is a cytokine storm. And that's causing this kind of non-cardiogenic permeability type of pulmonary edema. Okay. So again, so you have the onset of symptoms. The ratio, it's acute onset. This is the European consensus criteria. We have a set of different criteria that we use. One is the PF ratio is really less than 200. If it was 200 to 300, we used to call it acute lung injury, and that used to be the old way of doing things. We had bilateral infiltrates on chest radiographs. And the wedge pressure was low. And this was really important because this wedge pressure or this cardiac filling pressure or this indicator of cardiac function was such that the heart was still good. So we couldn't blame it on the heart. We had to blame it on something else. We ruled out hydrostatic pulmonary edema. So that was the old way of looking at it. So here's a patient who's dry, the wedge pressure is less than 18, the ejection fraction is preserved, and this is what their chest x-ray looks like. This is severe ARDS. Interestingly enough, okay, COVID patients behave like they have ARDS, but a lot of times their chest x-ray doesn't look like they have ARDS. It's really kind of a funny situation. They behave that way, they look like they've got this pulmonary permeability syndrome, but they are actually not fluffing out the way the classical ARDS used to fluff out. I don't exactly know what to make of that yet. So in any case, so radiographic ARDS, they reflect the leakage of fluid with high protein content into the alveolar spaces, and what you see is this kind of like three general findings: a bilateral whiteout, asymmetric consolidations, and this kind of bat wing consolidations. Not that different from hydrostatic pulmonary edema. Okay, so if you just looked at this, you could not tell without looking at the patient whether this was cardiogenic or non-cardiogenic pulmonary edema. So again, you need more important, more further findings. So bilateral pulmonary abnormalities, predominantly, dependent. Okay, sort of looks like a dependent pulmonary edema. Patchy infiltrates, these are CT scan findings. Ground glass, this is really important, is so nonspecific. You can see this with aspiration, you can see it with viral syndromes that are subclinical, you can see it with so many different things. You can actually see it with CHF as well. And then basically, sort of like non-specific kind of findings, really. So this is your CT scan. You can see that, the dependent lung is really consolidated because why? Fluid goes into the dependent lung, right? So gravity pulls the fluid. And so what happens is you start to see this kind of dependent, and ultimately it starts to infect the entire lung, and ultimately the entire lung is full of fluid. There's also the Berlin criteria. This is lumpers or splitters. This is more of an academic issue. I put this in here so basically we can sort of use this as a risk stratification tool, because what the Berlin criteria has over the European consensus criteria is risk stratifying people by their PF ratio. The worse your PF ratio, the greater the severity, the greater the severity, the greater the mortality. So the greater the severity here, here it's less than 300, but greater than 200, the mortality is only 27%. Those people who are less than 100, the mortality is almost 50%. So Berlin adds a little risk stratification tool that perhaps the European consensus criteria didn't really have. You should know about it. You don't need to know the details. Once again, if you are looking at triage, these are things that you can use in the back of your head to try to find out how sick someone is, okay? So all this stuff is intertwined, okay? When we're talking about all these little intricacies like SOFA scores and things like that, acute kidney injury, multiple organ failure scoring, things like that, all this goes into your potential calculations in your head unless you have a specific tool that you can use to help triage someone into the right setting or potentially, in an ethical situation. So here you have ARDS. I'm not going to get into that. This is really what it looks like. So there'll be a test afterwards, and your job will be to reproduce the diagram. This is really what it looks like. It's a sort of a cytokine soup, okay, full of all these things. So this is your normal alveolus, and this is your alveolar lining cells and your epithelial and endothelial cells here. And you have an alveolar capillary membrane. And what you can imagine here is that the surfactant is keeping the lung open, but not only is the surfactant keeping the lung open, look how narrow the alveolar capillary membrane is. Oxygen diffuses relatively slowly. So what happens is oxygen doesn't like big barriers. So the greater the alveolar capillary membrane edema, the more difficult it is for oxygen to diffuse. Now, carbon dioxide diffuses fast. It diffuses 20 times faster than oxygen. But what happens is that the alveolar capillary membrane is such that once it starts to get inflamed, okay, you start to have this increased gap for oxygen diffusion. Not only that happens, but you start to see flooding of the alveoles with this proteinaceous junk, okay? So again, this is byproducts of inflammation. So not only is it hard for it to get through the alveolar capillary membrane into the cells, but also it's difficult for it to even get to the alveolar capillary membrane. So this is a lung that's actively inflamed and is in ARDS. Okay, so this is what it looks like. These are all those things that we've been talking about. Dr. Zulik mentioned here do we anti-inflammatory, do we cause an anti-inflammatory reaction here? Do we suppress this? We don't know. Here's the story. Teleologically, you think about a fever. People run a fever not because it's a bad thing. Fever used to be good, right? It helps cure certain low acuity diseases. So at what point, Vic, do we actually begin to use an anti-inflammatory agent? Because you start to suppress inflammation, and you suppress it at the wrong time, you might be making things worse. Obviously, a fever of 104 is not a good thing. But if you have a fever of 99 or 100, maybe that's a sort of a compensatory reaction that's evolved, with us over the years to make it so that we make our bodies more of a hostile environment for bacteria. Okay, that could be the reason. And this is why what happens here is so complicated. Which one of these would you pick? If you were going to pick one of these, TNF alphas or interleukin 8 or 10 or 2 or 4, which one of these would you pick to cause any sort of an antagonist reaction? What would happen to the others? We don't have, the state of science is not there, but it's a really good question. So in any case, so here's hypoxemia. So it occurs once because what happens at the alveolar capillary membrane, but also what happens is you start to have flooding of the alveoli, and then what happens is you start to see shunting, okay? And the shunting is such where the right heart is pumping blood through past alveoli that are not able to pass the oxygen on. So they're going through there and they're not picking up any oxygen at all, and that's called shunting. And so what happens is the shunt fraction increases in ARDS, and the fact is we've got to come up with strategies to minimize the shunt fraction. I'll talk about that a little bit, okay? One of the ways to do that, of course, is to recruit these alveoli, and that's what Sean's going to be talking about, because this is part of your functional residual capacity equation. And if you could blow enough air into there, maybe with PEEP, or maybe with lung recruitment, or maybe, we can get on top of the inflammatory cascade with antibiotics or whatever, we can start to open up this lung, we can start to I was making these slides. But in any case, we're going to stop there in terms of that. I do 158. Let's see, maybe. Arterial blood gases. Tia, what do you think if I do another half hour? Okay. So blood gas interpretation. Here is blood gas interpretation. Anybody here not used to interpreting blood gases? Okay, who here is very used to interpreting blood gases? See them all the time. Okay, so a few of us. Okay, very good. So this is your typical ABGs. So usually your normal pH is 7.35, 7.45. Once you get below this, you're talking about acidosis. Once you get over that, you're talking about alkalosis. Your PCO2 is usually in the 35 to 45 range. However, Sean will tell us that some people come in with a normal, absolutely normal PCO2 of 60. Okay, and they're truly compensated COPDers with severe restrictive or combined restrictive obstructive lung disease, and in which case what they have is a PCO2 of maybe 60 or 50, and their bicarbonate level is really high. Okay, we see that also in people with obesity, hypoventilation syndrome, and obstructive sleep apnea. Okay, so those patients come in very profoundly hypercapnic. I use the word hypercapnic. Many of the people in this community will use the word hypercarbic. It is a lumper splitter, pick your way of doing it. I will use hypercapnic. You will probably interpret it in your mind to say hypercarbic. I use hypercarbic to talk about bicarbonate levels, okay? So there's a little bit of a convention thing. I think it depends a little bit on maybe whether you went to school in Canada or the US. I just truly don't know. Anyway, so PO2 usually about 80 to 100, and then saturation usually somewhere in that range. That's not to say that lower saturations cannot be well tolerated. Lower saturations can be tolerated, and that's why sometimes when we're weaning people from the ventilator, we're okay with saturations of about maybe 90, 91, 92%, because that seems to be pretty good. And a lot of that goes back to the hemoglobin, oxyhemoglobin dissociation curve, where PO2, where a saturation of 90% translates into a PO2 of about 60. So PO2 of 60 is probably not a bad PO2 for most people, as long as their hearts can tolerate it. So what we do is we tend to sort of pick sometimes a little bit less reasonable values than going for perfection when they're on the ventilator. So how do we interpret arterial blood gases? Well, the first thing we do is we look at a pH. If the pH is high, then the patient's alkalemic, okay, or they have an alkalosis. On the other hand, if it's low, they're acidosis. I already said that. Now, if they're acidotic and the pH is low, we have to ask ourselves why, okay? If the PCO2 is high, then what happens is it is a respiratory acidosis. That means that their PCO2 is high, they are in respiratory failure, they have a hypercapnic respiratory failure, and they have a respiratory acidosis. How do we fix that? We ventilate them, right? Sometimes we can ventilate them. We might be able to give them Narcan or flumazenil. We talked about that already. Or maybe what we can do is put them on CPAP. Okay, you don't put the COVID patients on CPAP, but typically you can put these folks on CPAP and they will blow off a little CO2, decrease their sedation. Okay. The other thing is that if the bicarb is low, then they have a metabolic acidosis, and that means that they have perhaps a lactic acidosis, or they have a diabetic ketoacidosis, and there's things that we can use, for example, looking at the anion gap. We can decide if it's an anion gap versus non-anion gap acidosis. It's maybe a little bit too much information for today, but we're going to talk about is they're acidic. If they're respiratory acidosis, what we do here is we actually help them breathe better. On the other hand, can we correct a metabolic acidosis with hyperventilation? Absolutely, okay? So what happens is you can go ahead and you can take somebody like this, you can give them bicarb, but one of the things you can actually do is to actually help them breathe more, okay? And that's why people who come in with septic shock, and we talked about this, they're tachypneic because they're blowing off CO2. So they're blowing their CO2 down to subphysiologic levels in order to compensate for the metabolic acidosis. So that is a compensatory mechanism that patients can sometimes do, but then they get tired. And when they get tired, then they run into trouble. Yes, Dr. Rinkar. So what you don't want to do is put them on a vent, paralyze them, and give them a minute ventilation lower than it was, because then you're going to make them worse. On the other hand, what you're trying to do is hopefully do two things. To support them so the work of breathing isn't so much that they have a heart attack or something else, and at the same time, treat the metabolic acidosis. So that may mean put them on an insulin drip and give them fluids, or it may mean that you go ahead and give them bicarb, or you fluid resuscitate them to fix the lactate level. Whatever the cause is, you want to get to the underlying cause. So you're using the mechanical ventilator not as a treatment, but as a way of buying time in somebody who could not have done it otherwise by themselves. You're absolutely right. So again, same is true for alkalosis. If the PCO2 is low, you have a respiratory alkalosis. They blew their CO2 down and they became alkalotic. And that's usually a sign of pain or something like that, okay? Maybe sometimes neurogenic, okay? Neurogenic hyperventilation can cause the same kind of picture. And that's a compensatory mechanism as well, Vic. So on the other hand, if the bicarb is high, they have a metabolic alkalosis. Sometimes you see this, for example, in people who get transfused a lot. And what happens is they get 10 units of blood in the operating room, and then all of a sudden the citrate buffer is suddenly metabolized into bicarbonate, and now all of a sudden you see their pH go way up, and all they're doing is to just you got to wait for that bicarbonate to go away, and it'll go away sooner or later. It's usually not going to cause a problem. So how do you interpret blood gases? You look for hypoxemia. So look at the PO2 and the SAT levels. We talked about how important that is to oxygen delivery. We want to decide, once again, if it's alkalotic or acidotic. So where's the pH level, the thresholds? This should be 7.45. Look for PCO2, hypercapnia or hypocapnia, and then look at compensation, okay? So once again, people can be chronically compensated and people can be acutely decompensated. So we have a patient, a pH 7.32, PO2 78, PCO2 31, bicarbonate 19, and a SAT of 89%. So what do you think? FiO2, we don't know the FiO2. PO2 and saturation certainly indicate mild hypoxemia. What are we going to do? Give oxygen, right? Simple. That's easy to fix. I'll give them some nasal cannula or increase the FiO2. pH indicates what? Acidosis, okay? And so they're a little bit acidotic. And the PCO2 here indicates that they sort of a little bit of respiratory alkalosis. What else can we say about this case? Yep. Okay, you got it. Okay, so it's a partially compensated metabolic acidosis. Way to go, Dr. Zulik. So that's what it is. Okay, it's a partially compensated metabolic acidosis with hypoxemia, if you're going to be absolutely correct about that. So here we have a patient, pH 7.37, PO2 65, PCO2 58, bicarbonate 29, and saturation of 87%. What does this tell you? You guys are right on. I can't teach you anything. So he's got a little bit of hypoxemia. It's acidosis, right? pH a little bit slightly acidotic, maybe not so much. PCO2 indicates respiratory acidosis, so the PCO2 is way higher than we would have liked it to be, okay? Unless this is chronic, but if it was chronic, this bicarbonate would be even higher than that probably, okay? The PCO2 indicates respiratory acidosis. Bicarbonate indicates also, so here you have a metabolic acidosis almost fully compensated. This is your typical COPD patient, okay? So this is where you stand with a COPD patient who is chronically hypercapnic, and they've got a sort of a almost fully compensated, not completely compensated, chronic respiratory acidosis. So last question, which one of these is worse? Okay, you have a patient here, and their pH is 7.38, the PCO2 is 22, the PO2 is 75, the bicarbonate is 20, and the SAT's 93. And you have another patient with a pH of 7.33, the PO2 is 46, the PO2 is a little bit better, the bicarbonate is about the same, and the SAT is 95. Yeah. So what happens here is it's hard to say, okay? You have to put it into context. But if this was your same patient, the second state is a worse state to be in. Why? Yes, they're getting tired. You're absolutely right. They're getting tired and they cannot blow their PCO2 down anymore, and you can see the pH dropping. Good call. This is a patient you really have to watch for acute respiratory failure, potentially take them into a monitored setting because they're going to crash. I think we're almost there, guys. Very quick mechanical ventilation. I'm not going to spend a lot of time on this because you know what? The principles are really all I want to cover. Sean will teach you everything you need to know. Case study? Okay, well, forget about the case study here. Let's just go on. These are the things that we can do. We can change the mode. We can go from CPAP to SIMV to pressure control to volume control to pressure regulated volume control to a number of different kinds of ventilatory modes, but you have to pick a mode that you're happy with. Yes, Dr. Zulik.
Sorry, Nick Russ, but I have noticed now that most of the time in the newer sites, they're not getting blood gases. They're getting venous.
Yes, and getting venous blood gases is good as long as you understand the normals. There's something about poking a patient. It also creates an artificial state. So if you didn't get the blood gas on the first try and you're sort of looking for the blood gas and they're hyperventilating and the numbers probably don't mean that as much as you thought they did. On the other hand, if they're on a ventilator and they have an arterial line in, then that certainly is a way to measure arterial blood gases. But you're right, getting a VBG is a perfectly okay alternative. You just then have to couple that VBG with the SAT monitor. Right, so you have to have those two pieces of information simultaneously. But it's a very good point, getting VBGs. So then you have to pick the FiO2, you pick a tidal volume, you pick a rate, and you pick PEEP. These are basically the things that you can change on mechanical ventilation. So what happens here is, I'm not going to spend a lot of time on that question, but here it goes. So we start to look at different parameters on the mechanical ventilator. Again, the saturation here is 88%. The blood gas shows this, pH of 7.38, PCO2 36, PO2 57, and then what we're doing is we're looking at our peak airway pressure of 52, our plateau pressure of 48, we've got 0 auto PEEP, and our respiratory rate is 18. Still learning how to make slides. I apologize that you have to sort of shift up and down like this. But in any case, any thoughts here? What can we do here? We could probably increase our PEEP a little bit, okay. Certainly you have room to move. There's no auto PEEP going on, okay. Very good. Are you happy with the blood gases? PCO2 of 36, PO2 of 57? Probably not. So you may want to increase your FiO2 as well. And again, it's a way of working your way through this. So I'm not going to spend a lot of time on problem solving. And again, I promised you that I wouldn't do this. I do want to give you a couple of quick principles here. So determinants of oxygenation. What determines oxygen? FiO2 is the easy one, right? So somebody's hypoxemic, you put them on a nasal cannula. For every liter increase in nasal cannula, Sean, roughly, depending on the patient, depending on their minute ventilation, depending on how big their breaths are, roughly 3%, right, for increase in your FiO2, right? So if you put someone on 2 liters nasal cannula, you bump them up to about 27% FiO2. That's kind of a rule of thumb. That kind of works, but it's very variable depending on patients. Then the other thing is you can change your mean airway pressure because your mean airway pressure recruits lung. And Sean's going to spend more time about lung recruitment. So your tidal volume you have to be careful about because you don't want to over-distend the lung, but you want to recruit as much lung as you possibly can. You also can improve oxygenation by changing the IE ratio. So if you leave the lungs expanded for a little bit longer, we used to call it inverse ratio mechanical ventilation, then that changes the way that the oxygen it has more time to recruit lung and FRC. We can change inspiratory flow rate to some extent. We can change PEEP. We can actually impose a little auto PEEP. We usually think of auto PEEP as being a bad thing, but sometimes auto PEEP is not such a bad thing. And we can change the inspiratory waveforms. These are all adjunct ways to improve oxygenation. This is a golden slide, okay? Remember this, because this is going to tell you that minute ventilation is the way that you control PCO2, okay? There are a lot of secrets out there when we talk about mechanical ventilation. One is, how do you fix the PCO2 that's really high? Well, if the PCO2 is really high, you fix it by increasing the minute ventilation. How do you change the minute ventilation? You change the minute ventilation by either increasing the respiratory rate or the tidal volume, or both, right? So minute ventilation is equal to tidal volume times the respiratory rate. That is how we define minute ventilation. Minute ventilation is proportional inversely to the PaCO2. So the higher your minute ventilation, the lower your PCO2 is going to be. So when you start to think about fixing somebody with a respiratory failure that's hypercapnic, okay, or if the patient isn't breathing well, you have to fix one of these variables in some of the ways that we talked about. Flumazenil, Narcan, intubation, CPAP, something to go ahead and increase their minute ventilation. So in order to treat a respiratory acidosis or hypercapnia, you want to decrease the minute ventilation, and to treat metabolic acidosis, you want to increase the minute ventilation. Maybe to treat respiratory acidosis, hypercapnia, yes, you want to increase. Yep, you're absolutely right. Yep. And to treat metabolic acidosis, you have to do the same thing. Yep. Sorry about that. So, okay, very good. I have people who are still awake. Yay. Okay. So initiation and mechanical ventilation, once again, use a familiar ventilation mode. Internal, you have to pick an initial FiO2. You want to start maybe 1. Some people start 60, whatever. You want. It depends on the situation. The patient's profoundly hypoxemic and you just intubated them, they just finished a code, maybe you want to start at 1 for a little while and get things under control before you start to drop it, okay? But certainly you want to keep the SAT probably above 92. The initial tide volume, somewhere about 8 to 10 mLs per kilo. And the way that works is that this is not ARDS ventilation. This is just straight old mechanical ventilation, okay? Our ARDS-NET, ARDS ventilation uses lower tidal volumes than that, and we'll get into that perhaps as we go on. So rate and minute ventilation are appropriate to the clinical needs. Keep the PEEP to support oxygenation. Usually start at about 5 because we consider 5 to be physiologic PEEP. We believe that when people close their vocal cords, they have a little residual PEEP in their lungs. It's about 5 centimeters of water. So we believe that that's physiologic PEEP. So we start off with that, but you can rapidly start titrating the PEEP up in order to decrease your FiO2. People talk about FiO2 as being toxic. So certainly oxygen toxicity is a real thing. It generates free radicals. It's like leaving your butter in the hot sun. You watch it get rancid. Well, the lipid bilayer membrane of the alveoli, okay, the cells lining the alveoli, that's a lipid bilayer, and that begins to get oxidated very quickly with high FiO2 concentrations. That's a real thing. So we try to get down to about 60% as quickly as possible. And we use PEEP as a way to sort of crutch our way back up there. And then call a critical care consultant for help if you need it. So again, you know, there's a bunch of things that happen. We usually think about PEEP as being an oxygenation tool, but PEEP is also really important because PEEP, as positive end expiratory pressure, works into the compliance formula as well. So by increasing someone's PEEP, you can actually improve their pulmonary compliance, not just improve their oxygenation. So you open lung. Open lung is so much more easy to ventilate than closed lung. Right, which is the baby's hardest breath? The first breath, right? Is when they open up all that collapsed lung, and once they're done, once the lung is open, it's so much easier to keep it open. So getting the lung open is very, very important. So PEEP not only is good for oxygenation, but it's also good for ventilation because it improves your pulmonary compliance in addition to recruiting functional residual capacity and decreasing shunting, okay? So it does two things all at once. Did I say that too fast? Okay. So PEEP is really important because, yes, Kia? So I'm seeing high PEEP levels. So again, I don't see it. I get reports of high PEEP levels, okay? So what happens is the PEEP levels are usually very high in the 15 to 20 range. Apparently, Sean, correct me if I'm wrong, but they're using what we used to call almost super PEEP levels once upon a time, to sort of 20 of PEEP. And you've got to be careful, right? Because PEEP is positive end expiratory pressure. So again, remember we talked about how the cardiopulmonary system interacts with each other. And so if you've got elevation in your PEEP levels, you've got to be watching your cardiac output really closely because once again, you know, as your intrathoracic pressure is continuously elevated, you've got to be maintaining that preload high enough so the heart can still pump. If not, then you're helping to progress into a sort of a multi-organ system failure because of tissue hypoperfusion. Okay, so I have to say that over again, right? Okay, so what happens is we think of PEEP as opening lung because PEEP opens lung that is collapsed. And if you apply the PEEP to the lung, it opens the lung, and what it does is it actually improves ventilation perfusion matching. So it decreases shunt. You now have open alveoli, which are being oxygenated, that are being perfused, where you basically had collapsed alveoli previously that were being perfused, contributing to shunt. So you actually improve oxygenation by doing that, and what we're doing here is recruiting functional residual capacity, which is FRC, and as we increase FRC, what we're actually doing is we're recruiting lung. So we're actually keeping the lung open, right? On the other hand, it's also a compliance tool because what it does is by changing pulmonary compliance, by leaving the alveoli already partially open, it's not as hard for the lung to expand that alveoli. Anybody here ever see lungs being extended in the OR after a thoracotomy? And the anesthesiologist is squeezing the bag and you see it's like a little bubble wrap, a little alveoli are opening. And what happens is it's really hard to open those alveoli. So once they're collapsed, they're collapsed. So if you have them partially open, compliance is change in volume divided by the change in pressure. So once they're already open, you're able to now ventilate them so much more effectively because the lungs are already open. So we actually have this thing called the open lung concept. And the open lung concept depends on lopping people with lung opening procedures and using lung recruitment tools, which Sean will talk to you a little bit about. And it's so important to understand these concepts. Yes? You're probably right. Okay, so continuous application of PEEP will open lung. Okay, but it takes a while. Okay, you know the problem is you're so advanced. I have to give you all these advanced answers. So the time constant of inflation of alveoli. Okay, the time constant of inflation of alveoli, one that are potentially depleted of surfactant, is very, very long. Okay, so you have to apply PEEP for a long time. So as you're applying that PEEP into that lung, some of that PEEP is going to go to good lung, and you're going to over-distend the good lung while you're trying to open the bad lung. So again, using PEEP can be good and it can be bad. That is why more recently what we're doing is we're using lung recruitment tools to apply PEEP for short periods of time to help expand these closed alveoli, and that is a way that is potentially a little bit more lung protective as part of our lung protective strategy of ventilation. But it's really good questions, Vic. I'm going to have you come down and finish it. Okay, being really good. You're way past me. Okay, so these are the things that you're going to set on the mechanical ventilation. Now, this is I want to go back here. Some people like volume control modes, and some people like pressure control modes of mechanical ventilation. In the end, it's probably roughly the same, okay? There are subtle differences based on the waveforms and the way that the pressure and the flow are applied to the lung. But if you think about it, the volume and pressure are related through compliance. So if I set a tidal volume at a certain level, given that the compliance hopefully isn't changing, because I'm sort of doing a static sort of maneuver, if I set a tidal volume, it's going to set off at a certain pressure. On the other hand, if I set the pressure at the same pressure that it took me to get a certain tidal volume on volume control, I set my inspiratory pressure to the same thing, I'm going to get the same tidal volume, roughly, right? Okay? And there's subtle differences here in waveform, which there are some slides in your handout to talk about. In ARDS, you have poor lung compliance, we have high airway pressures, and again, I think in COVID, we're not seeing those really high airway pressures. But I think we're using the PEEP to oxygenate because we cannot oxygenate these folks. Their compliance is actually not that bad. Sean, am I correct? So tidal volumes needed are lower. We're using a sort of lung protective strategy of 5 or 6 mLs per kg, predicted body weight, and then using the plateau pressure as basically a way to define compliance. We don't have time to get into that. We're using PEEP to improve oxygenation. We're also using PEEP to recruit lung and improve our compliance. And sometimes we have to use a strategy called permissive hypercapnia, which means that we don't ventilate the patient back down to perfect Harvard numbers. We go ahead and we ventilate the patient to pretty close. So as long as we have a pH greater than 7.2, we're pretty happy with that. As long as it's not overly acidotic, and we're still able to maintain that patient, we let the PCO2 ride a little higher because we know that imposing so much more pressure on those lungs will actually cause shear stress and fibrosis and begin to hurt those lungs more, okay? So that is what we do. We try to use a lung protective ventilation strategy, and that's very important. Here, I only have about 5 minutes left to go here. So again, what happens here, peak airway pressure, this is our plateau pressure. This is a sort of an indicator of compliance, and the idea is to get these to be pretty close to normal. So the high peak airway pressures with normal plateau pressures indicates a resistance to flow, okay? An increase in both is very, very suggestive of decreased lung compliance, which means that the lungs are very stiff and very difficult to ventilate. Volume control modes, I'm not going to get into. This is a preset tidal volume. Patient triggers, gets their full volume. It's a volume control. If every time the patient initiates the breath, they get the full breath, okay? So if they're poorly sedated, they're in pain, they're going to hyperventilate themselves. Sean will tell you all about this. Pressure control modes, interestingly enough, what they do is you set the IP, which is your patient preset pressure, your inspiratory pressure, and your volume depends on compliance. The patient still triggers and gets the full volume. What's different here is some subtle differences in curves. So if you look at the kind of, waveforms that you have under pressure control and volume control, you have this decelerating kind of waveform, which you can play with now. You can actually change the way that these waveforms appear, but this is potentially a little bit more physiologic. And perhaps applying this sort of pressure more continuously than this sort of rapid rise is a little bit more physiologic, going back to Vic's question, because what's going to happen here is you're going to more evenly potentially distribute the ventilation between good lung and bad lung, and you're going to try to keep those alveoli open. So it's a little bit better perhaps. And then, of course, there are disciples of either pressure control or volume control. I will tell you that children are almost ventilated in a NICU with almost all the time with pressure control modes, okay? Because that is a more potentially physiologic way. Pressure regulated volume control is an adaptive targeting scheme. Pressure regulated volume control, Sean will tell you all about this. This is the story with PEEP. PEEP works on compliance, right? So change in volume, change in pressure, this is the formula for compliance. You understand that there's two inflection points in the pulmonary compliance curve. One is the lower inflection point, at which point you develop atelectasis, and the second is the upper inflection point at which you begin to hyperinflate the lung. Sean will tell you that we can actually determine this at the bedside. We can use a tool that we use in the ICU to determine what we call optimum PEEP levels, okay? In order to do this, the patient has to be heavily sedated or paralyzed, but you can find out where these inflection points are. If you let the patient get below the lower inflection point, they will develop atelectasis and they will have shunting and they'll be hypoxemic. Yes. So. So the question, Sean, is that what kind of a compliance curve are we seeing in COVID? Permeability.
Well, it seems the PEEP is what's kind of preventing that to happen, because if by permeability injury you mean that they're going into ARDS, and the typical presentation, that's not what we're seeing. We're really truly seeing patients. We have a patient yesterday I was taking care of who's on 18 at PEEP. So you would think, oh my God, she's on 18 at PEEP. When I walked in, she was on 60% FiO2. That's severe ARDS, right? She had a ventilating pressure of 8 centimeters of water and 600 milliliter tidal volumes. So she was clearly not a stiff lung, but yet she still required this support.
So it's remarkable. I mean, I think they're not stiff lungs, they're just requiring high PEEP. It's kind of an unusual injury. This is what I'm hearing from Sean and others. I'm going to probably finish with this slide because I think it's really important to get through this. But this is where we over-distend the lungs. This is where we have potentially the point where we're compromising cardiac output. We're over-distending, we're shearing these alveoli, we're ripping them apart with over-distension. And so we have a place to be. Where do you want to be between the two inflection points? So you want to be above the lower inflection point, but you want to be below the upper inflection point, and that is why sometimes determining the optimum PEEP. And so I'm sure, Sean, when you talk about how much PEEP these COVID patients are requiring, you're probably looking at the optimum PEEP, right? You're actually doing the maneuvers? No.
Just turning it up to get they're not desaturated.
Right.
In other words, we're titrating PEEP based on whether or not we can oxygenate.
Okay. So again, it sounds like a complex management scheme. It's 2:30, so again, I overzealously prepared. I had too many slides. I'm guilty again, but the stuff is all there for you. We've had a lot of good questions. Are there any more questions that you want to address right now? Because I think a lot of this stuff here, we're going to be able to cover in our workshops. So the way, if there are no questions here, I'm going to take a 10-minute break, and then we're going to come back, we're going to reconvene, and we're going to come down here and we're going to start working our way through the skill stations, okay? So I think the way we're going to do the skill stations, there are folks here for which a lot of stuff will be review, And so what we're going to do is work our way through the skill stations, and then people can come back to certain skill stations and practice. So if you want to learn how to intubate or put in an IO line, and then what we'll do is there's a Foley catheterization here. There's nasogastric tube placement here. There is we're going to need a volunteer to get up here so we can find their IJ and use the sonogram to sort of localize the IJ so people can see at least what it looks like and how easy or hard it is to find. And then what we have here is some intubation mannequins, and we have a test lung, so you can start to ventilate using different kinds of compliance. We have a regular ventilator that you're going to see in most of the ICUs, and then we have the LTV. And then we also have a glide scope for practicing intubation. So take a 10-minute break. We'll come back and, yes, Tia? Proning patients. Okay, so that's a really good point. So Tia had one last question about proning patients. Proning patients is really important. It is another way of helping people get through ARDS. And the way that proning works is, we use Flolan, right, which is epoprostenol, which is another way of taking care of ARDS in some places, or a decreased shunting, and we certainly use that. But here's a typical proning bed, okay? So what happens with the proning bed is you strap the patient into the bed and you turn the patient around. And the idea here is not to prone them and leave them prone. The idea here is to rotate them. Because what you're actually doing with pronating is you're actually moving extravascular lung water between areas of the lung, okay? So as it turns out, the supine chest here, the sternum is here, the dorsum is here, and this is the lung. So you can see a lot of lung volume down at the bottom and less lung volume up at the top, right? So what happens is there's a lot of dependent edema occurring here. So here, the idea is you've lost a lot of effective surface area in this supine position. So when you prone the patient, what you actually do is you use gravity to move the fluid into the dependent portion of the cone. If you do move the fluid into the dependent portion of the cone, you now have the ability to expand the non-dependent part of the lung. And so this proning is actually mobilizing extravascular lung water. And it also is, by the way, it's also good for secretion management because you're also moving secretions in and out. So the fact is, if you're suctioning at the same time as the patient can tolerate, you're doing that as well. But proning allows the redistribution of extravascular lung water in order to improve not only their compliance potentially, but also their oxygenation. So if you start to look here, this is your gas to tissue ratio in a sort of a normal lung here, and then looking at the ARDS lung in the supine position. What happens here is that you actually improve the oxygenation by improving the gas to tissue ratio in a prone lung by moving the extravascular fluid around. And again, what you're going to do is you're going to be proning for some time, and then you're going to be going supine for part of the time. So it is not a full-time thing to be proned. And proning doesn't have to be done on this bed. It can actually be done on a regular ICU bed, but it's a little bit more difficult to do. You just have to wash the tubes and the wires, and it is definitely a way of doing this, and it is a very accepted way of managing ARDS. In fact, there are early data looking at the SARS or the CAPS or COVID or whatever. When all this data started to come out, there's a strong suggestion that proning was the only thing that made a difference. Okay, so again, that was the early data that came out. I don't follow this quite as well, but I do think that proning is a tool that we probably should be using more in the care of these patients, just based on the data that had been published in the last month or two on this topic. Great question, Tia. Thank you. Go have a break, and we'll see you in a few minutes.